Well, we have a little talk today on prenatal alcohol exposure and FASD, screening, brief intervention, and referral. So we'll let them introduce themselves when we switch in a moment, but that's our talk for the day.
And check out our upcoming echoes. One of the fan favorites, Dr. Resnikoff, is going to be speaking on the next session on approaching inpatient civil commitment for SUD. And I know that's an area that probably a lot of us have questions about, happens infrequently sometimes. And kratom updates are going to be great. Kurt always talks about how it's really potent and causing lots of problems. So important for everyone to know about kratom. And then case reviews is going to be a great session by Kurt on November 12th. And if you want to check out other echoes, look on the bottom of the screen and they're out there if you want to attend.
All right, remember, if you have any questions, please feel free to reach out. Always happy to help you with some new ideas that you might need if you've got somebody that's a little complicated. But you can get Aaron there and myself. Our numbers are at the bottom. So feel free to chat with us.
And then just a reminder that Stratus is the home for the CORE website, which is just an area where there's resources, sample policies, and protocols. So don't reinvent the wheel. Check this out first. Hopefully there's something that's helpful. And then we have some Zoom polls. Thank you for putting this slide in here.
I had no idea it was there.
Which of these best describes your role? Provider, nursing, pharmacist, behavioral health, mental health, or other? All right, so a mix between provider and behavioral mental health today. Awesome. Kurt, you want to do this one?
Yes, as a part of your role, you get to pick one of the four. I am working or have worked with MOUD patients, clients. I don't work with MOUD patients or clients. I don't work with MOUD patients, clients, and do not plan to ever in the future. And last but not least, not applicable, or I am not involved in patient care. So most of us are doing it. So perfect. All right. So with that, we will turn this over to our speakers and we'll let them introduce themselves and then we'll kind of move on to the talk. So thanks everybody for coming today.
All right, thank you so much. Lovely to be here. My name is Julia Konko-Zebel. I'm a pediatric neuropsychologist with Proof Alliance. I'm also the Senior Program Manager of Healthcare Initiatives there. So as part of my role, I lead the FASD, or Fetal Alcohol Spectrum Disorder Diagnostic Clinic at Proof Alliance, and I provide diagnostic training to clinicians as well. And today I'm joined by my colleague, Kendra Glutt, who is the Director of National Programs at Proof Alliance. Kendra has been leading screening and brief intervention initiatives for FASD here in Minnesota, as well as providing training on these topics at the state and national levels. And what I'd like to do is just briefly introduce Proof Alliance and then jump into our presentation. And I'll be speaking for the first half, and then I'll turn it over to Kendra for the second half. Let's see here. A little slow on the slide transition. Let's see if I can get that. There we go. Okay. If you have not heard of us, Proof Alliance is a Minnesota-based organization and we have national reach. We have been around since the late 1990s, and we're based out of St. Paul, Minnesota. Our mission is to prevent prenatal alcohol exposure and also support those living with FASD and their families. Within Proof Alliance, we have an array of services and programs. We have an FASD diagnostic clinic. We also provide professional training for healthcare providers, educators, and social workers. We provide prevention and education and support services for families and caregivers, as well as advocacy around policy at state and national levels. We're happy to be here today, and our objectives are threefold. As the majority of you are providers that work with pregnant individuals, adult populations, and/or pediatric populations, we want to explain the need for prenatal alcohol exposure screening and brief intervention. We also want to build your confidence in incorporating these practices into your clinical visits, or if you are already doing this, to strengthen these practices as a part of your visits. Finally, we want you to leave this training feeling like you have some knowledge regarding referrals. So you've got some information in your back pocket. You know where to send folks who are screening positive for alcohol use during pregnancy or for children with prenatal alcohol exposure and developmental concerns. And we are hoping to share information with you for the next 45 minutes, leaving about 10 to 15 minutes or so for questions afterwards. You are welcome to put questions in the chat as we go along, which we then can review at the end of our time together. All right, so before we dive into screening and intervention and action steps, I really want to set the stage regarding prenatal alcohol exposure and fetal alcohol spectrum disorders in the United States. When I'm talking about FASD, I'm really talking about a range of conditions and characteristics that stem from prenatal alcohol exposure. And as with other neurodevelopmental disorders, there's a wide variety of presentations within FASD. Characteristics of FASD can include developmental delays, as well as cognitive, learning, language, motor, and behavioral regulation challenges. And we're talking children, but also into adulthood as well. FASD is the most common preventable intellectual and developmental disability in the United States. In recent studies, including Minnesota-based studies that Proof has partnered with some of our partners like Minnesota Community Measurement, Asset Incorporated, and Wilder Research, what we found is that healthcare providers' knowledge and training around FASD is often fairly low, with significant gaps in information around screening and brief intervention. So we're going to return to those knowledge gaps and discuss screening and brief intervention a little bit later in our presentation. I'm going to focus in on a few more pieces of information I'd like to highlight before we get there, but this is setting the stage for us and where we're headed. I know this chart is busy and not the easiest to read, but I do include it to point out that across fetal development, across gestation, alcohol can impact the developing fetus at any point. And because there is no established safe level or safe period of alcohol exposure, the public health message really remains that no amount of alcohol is known to be safe during pregnancy. And in fact, compared to other substances and prenatal substance exposure, alcohol is the most detrimental to the developing fetal brain. It is uniquely harmful in pregnancy due to its ability to cross the placenta and disrupt critical developmental processes. It can cause irreversible lifelong deficits. We know that alcohol interferes with cell proliferation, differentiation, migration, especially in that developing nervous system. And you can see that first line, that central nervous system, can be impacted by alcohol at any point during development. So we know that prenatal alcohol exposure at any point, again, can increase risk in terms of fetal concern. But we also know that not everyone exposed to alcohol prenatally does develop a fetal alcohol spectrum disorder. There are a variety of factors that affect how alcohol exposure will impact the developing embryo or fetus. And again, while there's no known safe amount to drink during pregnancy, in general, the more alcohol exposure there is, the more the risk increases that the child will be impacted. Research tells us that binge drinking, or 4 or more drinks in 2 hours, has been found to be particularly impactful and harmful to fetal development. Genetics also play a role. Genetics can also impact how much the child will be impacted by prenatal alcohol exposure. Twin studies have found that even with nearly identical alcohol exposure, the impact for each child can be different, such that, again, fetal genetics and metabolism are known to play roles in the development of FASD. We know that maternal nutrition affects fetal vulnerability as well. There's research regarding protective effects with nutritious diets, but also there are studies that show that iron deficiency during pregnancy, along with prenatal alcohol exposure, results in more pronounced neurodevelopmental differences and physical deficits in children. Other factors that can impact fetal vulnerability include the pregnant person's age, the timing of the exposure, and exposure to other substances as well. We know that drinking alcohol during pregnancy and using other substances does increase the risk to the fetus as well. And finally, the one variable that actually doesn't make a difference is the type of alcohol consumed. We know alcohol is alcohol, and one type is not safer, more safe than another. So again, that public health message is that no amount of alcohol is known to be safe during pregnancy. So now that we know that alcohol at any point increases fetal risk, let's talk a little bit about public health research related to alcohol use in the United States. And as I'm sure most of you are aware, alcohol use is common across all geographic regions in the US and across all racial groups and socioeconomic groups as well. A 2022 report from the CDC indicated that approximately 54 to 55% of adults who can become pregnant reported consuming alcohol within the past 30 days, and between 24 to 34% reported binge drinking in the past month. If you consider the base rates of alcohol use that I just mentioned, along with the fact that approximately 49% of pregnancies are unplanned, and some pregnancies may not be known for up to 6 weeks or more, public health estimates really put the number at about 3 million women in the US at risk for an alcohol-exposed pregnancy. So very high number. Another way to think about the magnitude of prenatal alcohol exposure in our country is that 1 in 7 pregnancies in the US are alcohol exposed. With information now showing that 14% of women reported ongoing alcohol use during pregnancy and 5% report ongoing binge drinking episodes. All right, so I've really painted the picture, hopefully, for kind of the magnitude, the prevalence. One more statistic for you to consider before we get into more of our actionable material is that currently the estimate is that 1 in 20 children in the United States has an FASD. So that's really 1 in every classroom here in the US. And this makes FASD more prevalent than spina bifida, Down syndrome, and even autism, which has a current prevalence rate of 1 in 36, according to the CDC. So there's a definite need for us to be screening and intervening both with our pregnant populations as well as our pediatric populations related to prenatal alcohol use and FASD. And I know we've got a variety of providers here, so I did want to touch really briefly on the characteristics of FASD for those that are working with pediatric populations. And I want to make sure you have a general baseline for screening and referral. So when we're thinking about screening for FASD, when we should screen, what are some causes for concern? We first want to know and debunk one myth that can be out there at times. Only a small percentage of kids with FASD have facial dysmorphia. So oftentimes I know in medical textbooks we see these pictures, and when these facial features are present, that's very helpful diagnostically, but often they're not present. In fact, 90% of kids with an FASD will not have facial features. So this is why FASD is often called an invisible disability. So as you can see here, these children are showing small palpebral fissures, which is the inner to outer eye opening. They're showing a thin upper lip and a smooth philtrum here, the groove piece above your upper lip. And kids with FASD can sometimes also show growth deficits in terms of height, weight, and head circumference, but not all the kids with FASD have growth problems as well. So it's important to note that when these facial features are present, they're helpful, but the majority of kids will not have these facial features. So when we are seeing kids, when we're working with children, we want to focus on neurobehavioral differences to really get at that invisible disability. And these three areas are areas where kids can often struggle. Kids with FASD can often show difficulty. That is neurocognition, self-regulation, and adaptive living skills. So neurocognitive differences can include developmental delays or intellectual disability. Again, it's important to note that about 25% of kids with an FASD are going to be in that intellectual disability range, so an IQ below 70. Most are not. So again, most kids are going to have below average, low average, even average IQ. Where we do tend to see differences is with executive functions, learning, and memory. So we'll talk about those as well just a bit. Executive functions can look a lot like self-regulation challenges, including problems with self-soothing and sleep for younger kids and infants, and problems with behavioral regulation, and also ongoing sleep concerns with older children. And school-age kids tend to show problems with attention and impulse control, trouble waiting their turn, difficulty following rules, inflexibility, and difficulty with effective problem solving, as well as sensory processing differences. Kids with FASD also show some challenge with adaptive living skills. So those daily living skills like communication, keeping their room tidy, clearing their plate, hygiene, as well as kind of social skills. One area where we do tend to see more differences as well is with communication, but kind of higher order communication skills related to social communication. So this can be difficulty understanding jokes, metaphors, or more abstract language. Memory problems and inconsistency in learning and recall are also a main concern for kids with FASD. So this makes teaching based on skill progression more challenging, as some days kids with FASDs are firing on all cylinders, and other days they may have really forgot what it is they previously learned. Other common concerns can include difficulty learning from consequences, like repeating the same mistake over and over again, low academic performance, balance coordination issues, and other visual, spatial, and motor concerns. And like other neurodevelopmental disorders, as you probably are thinking about, a lot of these characteristics overlap with ADHD, with autism. So FASD should really be part of that differential diagnosis anytime you're thinking about a neurodevelopmental diagnosis. FASD is often misdiagnosed as ADHD and ASD, and these conditions can co-occur, but they should also be considered and with anytime you're making that differential. Okay, so coming on back to screening and intervention. We've covered risk factors related to prenatal alcohol exposure. We've covered alcohol use in the United States and in pregnancy, and we've covered some characteristics of FASD in children. So we're circling on back. So now we know why screening and brief intervention is important. Let's talk about what's happening currently with screening and brief intervention. All major health organizations, the CDC, ACOG, AAP, all recommend universal screening for alcohol during pregnancy. And in general, screening is occurring during pregnancy. However, a CDC study did indicate that approximately 20% of pregnant people are still being missed, so are not being screened for alcohol use during pregnancy. What's even more concerning is that only 16% who were screened during pregnancy reported that they were advised by a health provider to stop drinking or reduce their alcohol use. That brief intervention piece is really missing. And here in Minnesota, we can see similar trends. From 2022 to 2024, Proof Alliance has partnered with two organizations, with ASTAT Incorporated, a Minnesota-based program, an impact evaluation organization, and Minnesota Community Measurement, an organization that collects, analyzes, and shares data on health quality to assess screening and brief intervention among providers here in Minnesota related to prenatal alcohol exposure. And when we're talking about screening, we're talking about clinicians using either a validated set of screening questions or homegrown screening questions to identify drinking patterns. When we're talking about brief intervention, that involves a short conversation with health education as well as a referral to treatment or resources. And consistent with kind of the national trend, 95% of the providers that we surveyed did feel that they were consistently sharing information regarding the risk of alcohol use during pregnancy. So that screening at some point, some information, some brief preventative information is happening. 81% described leadership support and commitment for this process. 71% had a plan in place for screening patients for alcohol use. However, less than half of the providers indicated that they have an established system for brief intervention if the patient disclosed use. So again, the screening is happening, maybe some brief education is happening, but beyond that, intervention and referral is not happening for most clinicians and providers. And so this gap here is what Proof Alliance is hoping to address. We want to make sure that basic screening is not only happening, but that brief intervention process is taking place as well. And I'd also add that from a pediatric perspective, while we don't have data to assess screening practices happening in developmental visits here in Minnesota, what we do know nationally and here in Minnesota is that FASD is significantly underdiagnosed and may also be misdiagnosed. So we know that that's also a concern in terms of that screening within pediatric populations. So I'm going to talk briefly about a few barriers to screening, and then I'll turn it over to Kendra to continue our discussion and then to really move into how to screen and what to do in terms of brief intervention and referral. So why isn't screening happening consistently? I'm sure we could all come up with a number of factors that are getting in the way. What has been addressed is, and what we have found here, especially in Minnesota, is that there are a lot of barriers it's a complex issue. Certainly there can be some barriers related to knowledge, lack of training, the diagnosis of FASD. It can be really complex and can seem overwhelming. When we're talking about screening prenatal populations and pediatric populations, with both, there's stigma around this. And we know that providers are concerned about how it might impact their relationship with their patient. One interesting factor that also was brought up and is really a major concern is that providers said, if I screen, but I don't know what to do with the information, what do I do? I mean, it's really a major factor. I call this kind of the now what question, like now what, so not having or not knowing appropriate actions to take, appropriate follow-up. I recently talked to one physician about this who said, if I don't know what to do about it, I'm generally not going to address it. And I think, that is something that is a major barrier we need to consider when we're working with providers. All right, so I'm going to turn it over to Kendra to continue our discussion.
Great. Thank you, Julia. As you heard, my name's Kendra Glett, and I'm also at Proof Alliance. And so we are hoping that today, first of all, from that section that Julia started with, maybe you learned something new about FASD or clarified some misinformation that you've heard about it before. And so now we're going to look at those barriers that Julia just talked about as far as why people may be avoiding the topic with patients and clients that they're working with, and start to address ways that you can change what you're doing personally in the practice that you're doing, or if you're in a space where you can create more systems change, how that might show up as well. So to start off, one of those, barriers may be the misconceptions that people have when they think about FASD. And so we want to start by looking at some of those implicit biases that may be coming into play when there's hesitancy about talking to people about FASD and drinking during pregnancy. And of course, first of all, there's that question of why. Why would someone drink alcohol while pregnant? We really want to make sure that we're thinking about all of the various reasons why there might be prenatal alcohol exposure. And first and foremost, a lot of pregnancies are unplanned. And so if people are drinking occasionally or binge drinking, not aware of their pregnancy, that's a large opportunity for those pregnancies to be exposed. Even if they learn about their pregnancy and stop drinking for the remainder of their pregnancy, there could have been a good period of time where there was alcohol exposure happening. Second of all, not being aware of the risks. I know there's still mixed messages out there when people are looking for information on what they can do during pregnancy. And we also know that there's misconceptions, especially with alcohol being legal, that maybe it's, we've heard that before multiple times, that people perceive it as less harmful. I stopped this substance, but I only drank alcohol, and that was, them trying to make a good choice. However, what they may not be aware of, and what a lot of people are sometimes surprised to find out, is that alcohol does more damage to the developing brain during that fetal development that results in lifelong damage to the brain. The impact is much more severe than those of the other substances. And so, unfortunately, a lot of times there's misinformation and mixed messages that all coincide and make it hard for someone to make an informed decision. And then lastly, of course, there's alcohol use disorder. And so for those of you coming from that space, you are familiar with the fact that as much as we can just say, don't drink when you're pregnant, and here's why, for many people, it's not that easy, and they're going to need that additional support to be able to not drink alcohol during pregnancy. So we just wanted to make sure that we're considering all of the reasons. I think a lot of people sometimes jump to the conclusion that it's only associated with those with an alcohol use disorder. And so really broadening the way that we consider why there might be alcohol exposure happening. Similarly, another way that we can see those implicit biases impact how we are handling these conversations is a consideration of who drinks alcohol when they're pregnant. So we want to emphasize that FASD is in all communities, races, ethnicities, socioeconomic groups, neighborhoods. It isn't something that is isolated to one population or demographic. It's throughout all communities. And another way to really think about a possible bias is if you pause and consider who you are assuming doesn't drink alcohol when they are pregnant. If you are picturing this type of person that you would think, I wouldn't need to have this conversation with them, they wouldn't be drinking alcohol during pregnancy, that also gives us a moment to pause and reflect on why we think that is, because we really can't depend on demographics alone to let us know who is and who isn't drinking during pregnancy. So in order to go forward with these conversations, we want to really think about how stigmatizing language can perpetuate the stigma that is associated with drinking alcohol during pregnancy and that shame and guilt. And so some of the ways that we're thinking about, just even if we're not having the conversation directly with the person, but with our colleagues, is using the word admitted. It's really easy for us to say that someone admitted that they drank during pregnancy, but that word admitted means that they confessed to wrongdoing, right? That they are saying that they did something that was bad. As we talked about, there are many different reasons why there might have been prenatal alcohol exposure. And so trying to notice when we're saying things like admitted, and we can just replace those with things like confirmed, that there was prenatal alcohol exposure or disclosed, shared this information, admitted, does, bring in that sense of this was something that was wrong that they did, that they should be ashamed of. We also just want to think about, do we always have to say that it was caused by a woman drinking during her pregnancy? Sometimes we can talk about FASD as just a prenatal alcohol exposure, or as you see in the second and third examples, we're focusing on the exposure. The child was exposed to alcohol prenatally. We don't always have to say because a woman drank during pregnancy, and really we want to take the focus off of who is to blame for this, and really what the point is that there was exposure that happened, and move forward from there. And then that last example is just reminding us all that we want to use person first language. So an FASD kid really paints the picture that that's all there is to that child when it's only a part of who they are. So we'd rather say a child with an FASD. So these are some prompts that we would want to provide if this helps you enter into this conversation. I'll just read through these so you can hear kind of how they sound, and if some of these sound like something you might want to use yourself or make your own, this might help you kind of enter the conversation. So the first one, we ask everyone these questions. FASD is more common than people think. It helps us to identify anything that could affect your child as early as possible. Not all children exposed to alcohol during pregnancy have problems, and we cannot predict who will and who will not, so we want to follow those children closely. Drinking alcohol at any time during pregnancy can have an impact on learning, mental health, behavior, or other health concerns. Many people drink alcohol before they even know that they're pregnant. Just because you may have consumed alcohol before you knew you were pregnant, it does not guarantee your child has an FASD, but if they do, there's a lot we can do to help. So hopefully these phrases might help you enter the conversation and really explain why we're talking about it. I think even if the conversation ends in someone saying they didn't drink alcohol during pregnancy, by you describing the reason why, because we know that this can be a result from prenatal alcohol exposure, it may give them some food for thought, and maybe in your next interaction, they come back and say, actually, I, reflected, and they're ready to talk more about what happened during pregnancy and that if there was some alcohol exposure. We also want to make sure we're thinking about where that person is coming from as they are also in the conversation. So we know that they may be considering what happens if I do say that I drank alcohol during pregnancy. Is this going to automatically bring in child protection? Am I going to lose my children? Do I trust who I'm having this conversation with? Who else in the community is able to be supportive, or will this be damaging in their own community if this information is shared? So a lot of this fear of judgment and bias can influence their decision on if they're feeling this is a safe place. But if you are transparent and explain why you're asking, what will happen with the information, and how we're there to support them going forward, and not trying to find a way to be punitive, we can really move them away from being fearful and into a better place of working together. So moving forward here, this is where individually, depending on who you are working with, you can think about some of these individual changes, such as reflecting on your personal bias, using this non-stigmatizing language, and also building a knowledge of the resources. So what do you have available or need to seek out in order to help people either have an alcohol-free pregnancy or move forward with having a child with an FASD? Similarly, if you're in a space where you're looking at health system practice change, those would be bigger changes you could do putting into place universal screening for prenatal alcohol exposure if you currently are not doing that? What is your protocol systems-wide when there is a positive screening result? What is the plan of action? And what resources are provided by the system so that those staff and providers can gain the knowledge and skills that they need in order to implement this? So we're going to talk about screening for prenatal alcohol exposure and encourage you to consider how this might fit into your delivery. We do want to emphasize that when we talk about screening, if it's not universal screening, meaning that we ask this question of all of our patients or all of our clients or individuals that we're serving, we are bringing in our own biases and discrimination by picking and choosing who we think we need to have this conversation with. So if it's universal, we're asking these of everyone across the board, and we're able to explain to this person, this patient, that these questions are asked of everyone so that they don't feel singled out or judged. And so we know, just similarly with other issues, that many other organizations, as you can see here, are in favor of universal screening. As Julia mentioned earlier, we were curious what was happening in our state as far as what people were doing when they did a prenatal alcohol screen. And only a small percentage of them were using an evidence-based tool when it came to these questions. We were surprised, I would say, to see how many, about over half actually had homegrown questions only. So they developed their own questions to ask about alcohol use during pregnancy. And then about 30% or so used a combination of an evidence-based tool, such as ACOG recommends the OUD, or maybe combining it or modifying it slightly, adding some of their own questions. So we wanted to say that we're not here to tell you that there's one and only screening that is the right tool to use. As long as you're having this conversation, we hope that it can help lead you to provide care for that individual. What we don't want is you to say just a yes/no question, because that's real easy for someone to simply say, if there was, did you drink alcohol during pregnancy? Yes or no. There's no opportunity to really have a conversation or explore that or get more information. And it's easier to not explore where there could have been prenatal alcohol exposure that they aren't thinking about. And of course, you can think about how this question might be asked in a way where we're definitely not going to get anywhere if someone's saying something like, and you didn't drink alcohol during pregnancy, did you? So we want you to really look at the questions if you have any questions in place, and know that we welcome a lot of different ways to get at this information. But we will provide you with our suggested screening tool, which I think is next. So this, I encourage you, you'll get a copy of these slides. You can look at those resources at the bottom to see where these questions are coming from. They're adapted from the Bright Futures guidelines and also the AAP implementation guide for screening for prenatal alcohol exposure. And since I had said we don't want a yes/no question, this is what we would recommend to open up the conversation more. So first of all, how far along were you before you found out you were pregnant? Before you were pregnant, and then you can ask how much alcohol or expand on that, what that would include. Did you drink? After you found out you were pregnant, how many times did you drink alcohol? And then during your pregnancy, how many times have you had 4 or more drinks in a day? So by asking in this way, you're giving them space to reflect on the fact that before they were pregnant, they may have been drinking. And you can match that with how far along they were in their pregnancy when they found out to help give you an idea of how much prenatal alcohol exposure was happening. It also gives them a way to answer in a way that after they found out they were pregnant, maybe they reduced their alcohol use. Maybe it's not black and white of no alcohol, but they made an effort and can have a space to talk about how they reduced their alcohol intake, even if it didn't stop entirely. So beyond the screening questions, we do want to help support what the next steps would be if someone does say that there was prenatal alcohol exposure. And again, because we know that you're joining this from a variety of places today, we know that some of you may be having these conversations with people you are talking to while they're pregnant. Others may be talking more about, after the child is born and is now here in front of us and is more on the pediatric side. So we're giving you a little taste of each of these. This is a very light touch. And so if you are interested in developing these skills further beyond what we can fit into our time together today, we'll provide those resources towards the end as well. And so, as many of you probably are familiar, SBI stands for Screening and Brief Intervention. Really what I want to emphasize here to help you all know how important and impactful this can be is that screening and brief counseling for risky drinking is considered one of the highest impact preventative services, second only to childhood immunization and tobacco use screening and counseling. So I know it takes a little bit of time, but it is very impactful for you to be able to just have this quick interaction. Of course, then beyond SBI, there's SBIRT, so screening, brief intervention, and referral to treatment. So especially in the spaces that you are in, this may be where the brief intervention may be enough for some, but others will need that additional support and treatment. And so these are resources that are provided as far as finding where we are referring those individuals. You may be familiar with these, but we wanted to provide resources, so you'll have a copy of those on your slide. Similarly, we just wanted to provide codes because if you're doing this work already, a lot of times we found out people were doing it, but they weren't coding for it. And so we wanted to provide codes that were available if you aren't using these while you're having these alcohol screening and brief intervention interactions. So again, you'll have a copy of that. As far as pediatric care, if you're screening and the child is, in the care of the person you're talking to, here are some next steps for you to consider. So we would want to document any information that came out of that conversation of amount, if there were other substances. Many times we see documentation where other substances are listed, but alcohol is not. And that's because alcohol was, again, considered more of a safer substance and or legal substance. And so we want to make sure that we don't miss the opportunity to document it because that documentation is very important when seeking out a diagnosis later on. If it's appropriate to make a referral to a diagnostic clinic and other support, and continuing to monitor the child for developmental delays and make sure that when we are documenting, again, like we said earlier, we want to be thoughtful of the words we're using to help make it non-stigmatizing. So if there is no prenatal alcohol exposure, we want to monitor and rescreen because if we see later on, perhaps some behaviors, some developmental delays that we learned about earlier in the presentation are showing up as the child grows, it could be a good time to revisit that conversation and reflect on exposures that could be causing the challenges for the child. So there's always a chance to revisit it. It doesn't have to be a one-time screening. And when it is confirmed, we would want to document it, give information, because many times, as you may all understand, FASD is not well known, and the parents or caregivers may not be familiar with FASD and what this might mean. So Proof Alliance is happy to provide information there. And then monitor for those delays. So if there are already developmental delays happening for the child, that's when you should refer for a diagnostic assessment at a clinic. And those FASD diagnostic clinics are listed on the Proof Alliance website. If there are no delays currently, but they become apparent as the child gets older, that's a good time to make that referral to the clinic. You may connect the family with early childhood services that can help with that developmental monitoring. And then also refer to appropriate support. So for instance, at Proof Alliance, we don't require an FASD diagnosis if they want to come to any family support groups or events or social opportunities to connect with other families. And we want to think about what other supports are available in that person's life beyond your interaction. So what other parenting support that can help them understand raising a child with a disability and IEPs at school? What other cultural supports are available to help them navigate this within their own system of beliefs? FASD specific support, Proof Alliance has a lot of ways that people can connect and either get one-on-one service navigation or meet other families and youth and kids with FASD, and that's really beneficial for those families. And community connectors, so if they have a recovery coach, if they have a doula, who else is in the community that they're getting support from that would benefit from understanding the challenges that are going to happen and be associated with FASD as well. So with that, these are just some things that you can find more information on for supporting those families on our Proof Alliance website. So we encourage you to check that out. And we also have a free app called Our Children Are Sacred. This is from our programming that is provided specifically for Native communities. So this was created by and for Native leaders and community members. So it addresses FASD through that cultural lens, and this is free for anyone to download. Again, with the copy of these slides, you'll be able to see some other fact sheets that might be helpful for having these conversations with those that you're working with. And if you feel like this was a nice beginning, but you really would like more support on how to have those conversations that sometimes can be tricky to navigate about prenatal alcohol exposure and do those brief interventions or continue to provide support throughout the pregnancy, we'd invite you to look at participating in the Safest Choice program. So this is something that Julia and I are faculty on and partner with the Boston Medical Center to provide nationally. A prenatal cohort is for those working with individuals during pregnancy and all about supporting that alcohol-free pregnancy and person during that time. And the pediatric cohort is, again, screening among the children and supporting the family. And so these happen twice a year. The pediatric cohort is going to start up again in February, just around the corner. And it's 10 sessions over 5 months and free continuing ed credit for many professional sectors. So go to the website if that's something that sounds like something you'd like to check out. If you're interested in letting us know how this landed for you, you can give us some feedback through that QR code, also available on your slides. And that's the content we have for you today. So with that, we can take questions.
Now, there was already a question in the chat about how long does it take to actually get in, for appointments for this type of evaluation? Is that a long thing?
I can take that question. Unfortunately, it is long. We in Minnesota, we are lucky in that we have anywhere between 10 to 15 diagnostic clinics, so we do have some options. But most clinics do have a wait list anywhere from 3 months to almost up to a year, depending on where you're looking. But I do refer you to our Proof Alliance website because we have a list of all those diagnostic clinics, and we recommend folks get on all of the waiting lists they can to kind of see what pops up sometimes with cancellations, or sometimes clinics just have openings so you can get in a bit faster. And doesn't solve the problem, but it makes me feel a little bit better that we actually have diagnostic clinics, and the majority of states do not have any FASD diagnostic clinics. So we're ahead of the curve there, but yeah, there's just such a need, and we don't have the space yet to see everyone that we need to see.
And for those of you that are connected through Centricare is one of those providing FASD diagnostic assessments.
Yes. Mm-hmm. And then also just add that there's a lot you can do even before the diagnosis happens. So if you go to the Proof website, we've got, family connectors, we've got resources, we've got ways to get the kids hooked up with things at school even before, maybe an official diagnosis is given. So it doesn't mean you have to wait on some of those things.
Mm-hmm. Other questions if people want to unmute? I have a question. I'm just wondering, is there anything that you guys see that, sometimes what if somebody shows up and they really have had no alcohol exposure at all, but they have something that mimics it? Are there things that kind of mimic this often?
There are a number of genetic disorders that can mimic this. Villocardial-facial syndrome, Delange syndrome. There's a few others as well. So the diagnosis, which we didn't talk about, but the diagnosis is really a two-pronged process. It's a medical assessment and a neuropsychological assessment. So the medical assessment is going to, really look at those kind of other genetic concerns or other diagnoses that mimic or are very similar to. So a lot of times it's ruling that out or getting some genetic testing if there are facial features. But again, majority of individuals, 90%, don't have those facial features. So it's really a lot of having that screening, having the questions being asked, getting that good history to be able to kind of really diagnostically point toward FASD.
It's interesting because you did make the comment about, alcohol is legal, right? And in our clinic, in our addiction clinic, it's like, it's still the substance that is the most destructive in our society, right? And now we look at medicinal marijuana, and one of the conversations we often have, people feel like it's safe because it's legal, when we all know that marijuana is going to turn out to be another alcohol as far as the effects on kids and everything else. Thoughts on that? We're telling people not to take Tylenol now, but yet I've not heard anything come out saying, okay, even though marijuana is legal, we shouldn't be using it during pregnancy.
Yeah, I think that's an uphill battle that, with alcohol we've been fighting, and now you're right, Kurt, we'll be seeing that with cannabis as well. And I think there is that kind of that false, equivocal or being able to compare like, oh, if something's legal, it's got to be safe, and that's not the case. And so, our goal really is to make sure people know that, there's a lot of danger or a lot of risk, at least, to drinking during pregnancy. And what that can mean. And so that safest message is just to, not drink if possible during pregnancy. But as Kendra mentioned, too, there's a lot of misinformation still out there, people that are getting information from online influencers or from, even folks in the medical field that are still like, well, you're, stressed and one glass of wine is not going to do anything. So those messages are things we still hear and are still struggling with as well. And I think that'll kind of be a similar pattern here with cannabis, unfortunately. So yeah, it's a tough one. It's a tough one for the public health message.
Other questions? Anybody want to unmute? Because I have more. You know, when you look at the United States as compared to other, other countries, I think it's interesting because I'd read some stuff on Ireland, which appears to be one of the worst at women actually drinking during time. How do we fit in globally as far as alcohol intake and pregnancy?
That's a good question, Kendra. I don't know if I know the answer as to where specifically we fall. We're not great, that's for sure. I don't think we are one of the worst. South Africa, Ireland are definitely some of the worst. But the issue is, it's like who's studying this and who's actually looking at prevalence. And if we aren't getting good, data around prevalence, we don't really know. I know a lot of times people say, well, the French, they're, drinking wine during pregnancy. And it's like, well, yeah, some of them might be, but they're not actually, FASD is not being studied there. So we don't really know what's going on. We don't know, how much they are and, what impact that's having. So it's kind of among those that have been studied. We're definitely up there, but also the awareness is higher, I think, than a lot of European countries. Ireland, though, luckily is really, the last 5-10 years, they've really taken on this issue and are making it a major public health issue. So that's great. But yeah, it is certainly a concern, I think, for almost every country out there. Not every country. There's certain countries that don't drink a lot of alcohol, but for those that do, it is definitely a public health concern.
Dr. Wilcox. Oh, sorry.
Okay. Sorry, I just realized the question popped up in the chat, but I was going to ask, because you have that additional training, the curriculum that you partner with BMC for, and out of curiosity, do you get a pretty good OB audience? I just, I think about the ones, I think about how unstandardized it feels across OB clinics to just do that prenatal screening, and I wonder if you get that crowd in your training.
Yeah, we do, and I think, it could be also assumed that everyone's already doing this screening and it should be in place, but as you saw from some of those statistics in the presentation, that's not the case. And it's really can be piecemeal from one person to another as far as who feels this is important to take time to talk about. So we do fill up our cohort each time. And we are really encouraging, instead of it being piecemeal, put it in, systems wide so that everyone, it's not getting missed depending on which provider you happen to see. And it's being asked in the same way and documented. So sometimes that's where there's an area for them to grow. Or sometimes they have something in place, but they need some guidance on some of those delicate conversations and what do they do with the screening results? Where do they go next? So those are some of the things that we tackle in that program. And it is to speak to the question about funding, that project that I shared, Safest Choice, is funded by HRSA. So far, it's unaffected. We have, it's a 5-year grant to provide this nationally. We're 1 year in to the 5 years so far. And we previously did it regionally. So it's an expansion. We've done it in 20 states over the last few years, many practices. So we hope that it remains untouched and we're able to continue the work there.
And then our work at Proof Alliance is primarily funded by Minnesota Department of Health, and so not impacted currently.
All right. I think we're just about at time there, Erin.
We are indeed. Well, thank you so much for the presentation. I certainly learned a lot. That was great.
Yeah,
well, thank you. Reach out to us, please do, if you have any additional questions or would like more resources or training. Thank you.
All right. Well, thanks again, guys. Wonderful presentation. We'll see everybody in a couple of weeks for Charlie Resnikoff, and please feel free to contact us with any questions. So have a good week.